Good morning, dear students. This my topic is management of hyperprolactinemia. So let's have a discussion. What is hyperprolactinemia? What are its causes and how it can be managed? So this is the flow of presentation. Overview of pituitary gland. What is prolactin? What is the definition of hyperprolactinemia? Use of cabergoline in management of hyperprolactinemia, followed by summary. So the majority of discussion will remain up to the oral therapy, which includes cabergoline only. So let's have a discussion about the pituitary gland. It has been clearly known that hypothalamus controls the pituitary, and pituitary is divided into two parts, that is the anterior pituitary and posterior pituitary. Anterior pituitary secretes various hormones, which includes growth hormone, which acts on the bones, muscle, and other organs, and it causes overall growth of the body. Another hormone which is secreted from anterior pituitary is the prolactin, which causes uh, secretion of milk from the breast. Another hormone which is secreted from the anterior pituitary is luteinizing hormone and follicular stimulating hormone. Both of these hormone ultimately acts on the ovaries in the female and testes in the male. So in the ovaries, this is responsible for estrogen production and progesterone production. And in the testis, it is responsible for testosterone production and spermatogenesis occur under the influence of this particular hormone. It also secretes adrenocorticotropic hormone, which acts on the adrenal cortex and causes release of the cortical hormones. Also releases one of the very important hormone, that is a thyroid stimulating hormone, which acts on the thyroid gland and causes release of the thyroid hormones. Posterior pituitary causes release of the one of the very important hormone which affects the water metabolism, that is a vasopressin or antidiuretic hormone, which acts on the proximal and which acts on the tubules of the kidney and causes reabsorption of the water and electrolyte. Another hormone which has been secreted from the posterior pituitary is oxytocin, which acts on the breast and uterus, and it also acts on the breast for causing the milk letdown, and it also helps in parturition. Coming to the pathophysiology of prolactin, prolactin is a polypeptide hormone which is consists of 119 8 amino acid, and it has a molecular weight of 28 kilodalton. Prolactin is synthesized and also stored in the anterior pituitary gland in a chromophobe cell, which has been called as electrotroph, which are located mostly in the lateral area of the pituitary gland. The major stimulating factor is the thyrotropin releasing hormone, and the major inhibiting factor is dopamine, which is suggested to be a prolactin inhibitor factor. Estrogen also causes improvement in the prolactin secretion by enhancing the effect of tryptophan releasing hormone and inhibiting the effect of the dopamine. Prolactin is down-regulated by dopamine and it is up-regulated by estrogen. Prolactin is normally present in a measurable amount in the serum, with a mean level is approximately 8 nanogram per ml in adult women. There is a range of this hormone, which depends on the various machine in which we are doing the test, and also depends on the kit we are using. Usually the range is up to the 27 to 30 nanogram per ml depending on the kit which we are using. It circulates in an unbound form and has a 20 minutes half life, and it is cleared from the liver and kidney. The main function of the prolactin is to stimulate the growth of the mammary tissue as well as to produce and secrete the milk in the alveoli. So it has a mammogenic and lactogenic function. Coming to the definition of hyperprolactinemia, prolactin is an anti-pituitary hormone which has a principal physiology and action in the initiation and maintenance of the lactation. Prolactin also plays a central role in variety of reproductive function. Hyperprolactinemia is the most common disorder of the hypothalamic pituitary axis, and hyperprolactinemia is a condition in which elevated prolactin level Could be physiological, like during the time of pregnancy. There are various stimuli which causes increase in the prolactin level, like sexual stimulus or handling of the breast also causes physiological elevation of the prolactin level. There are various pathological conditions which also causes elevation of the prolactin level, or it may be idiopathic in nature. There are various drugs which also causes elevation of the prolactin level. With the important drugs include the domperidone and various antipsychotic drugs. Hyperprolactinemia more commonly occur in the women, and the prevalence of hyperprolactinemia is about 0.4% in the unselected adult population, while in women with reproductive age disease it is 9 to 17%. Prevalence of hyperprolactinemia is about 9% in women with the adult onset amenorrhea and 17% in the women with the polycystic ovary syndrome. Prevalence of hyperprolactinemia in female and male infertility is about 25 and 11%. So now here we can see the hyperprolactinemia prevalence in the polycystic ovary syndrome women patients. Various diagnostic criteria has been used, and another is the Rotterdam criteria. So here we can see that the prevalence may vary from few percentage, that is less than 10% to up to the 60% in some of the population. Coming to the biochemical association of hyperprolactinemia with the hypothyroidism in infertile women. 100 infertile women, 60% had primary infertility and 40% had a secondary infertility included in this study. The incidence of hyperprolactinemia, that is the serum prolactin level of more than 15 nanogram per ml, was 46%. So this was the cutoff which depends on the kit which has been used in this particular study. The incidence of hypothyroidism in hyperprolactinemia was 28.26%. So higher incidence of hyperprolactinemia was found in infertile women and a positive correlation found between hyperprolactinemia and hypothyroidism. Coming to hyperprolactinemia and association with subclinical hypothyroidism, this is again a study which has been done in 2019, which is a cross-sectional study, and prolactin level of 481 subclinical hypothyroid patients were assessed. It has been found that 13% of the patients were male and about 87% were female. About uh, 91 females and 7 male had a high prolactin level. That is about 98% of the population have a high prolactin level in those patients who have a subclinical hypothyroidism. So prevalence of hyperprolactinemia in subclinical hypothyroidism is about 20.4%, which is 11% in male and 22% in women. P value is 0.05, which is statistically significant. So this suggests that subclinical hypothyroidism causes increased chances of development of the hyperprolactinemia. So now coming to the regulation of the prolactin level, here we can see that under the influence of TRH, there is secretion of the prolactin, and there is a positive effects of the estrogen level on it, and there is negative effect of the dopamine. So dopamine causes inhibition of prolactin secretion, and estrogen causes increase in secretion of the prolactin level. This TRH is reached to the anterior pituitary from hypothalamus under the influence through the hypophyseal stalk. Coming to the causes of hyperprolactinemia, so here we can see that the physiological causes of hyperprolactinemia, pathological causes of hyperprolactinemia, and pharmacological causes of the hyperprolactinemia. So physiological causes of hyperprolactinemia include ovulation, pregnancy, breastfeeding, stress, exercise, nipple stimulation, or chest wall injury. While the pathological causes of hyperprolactinemia includes prolactin secreting pituitary adenoma, which is comparatively a rare disorder, stroke effect from cellular or paracellular lesion, that is the compression of a stalk or when the stalk is damaged, renal failure, liver cirrhosis, primary hypothyroidism, polycystic ovarian syndrome, and seizures. Various pharmacological medicine like antipsychotic drugs, certain neurological medication, antidepressant, antiemetic like domperidone, opioids, and some of the antihypertensive. So these are the causes of pharmacological hyperprolactinemia. Now coming to the drug-induced sustained hyperprolactinemia, this include antipsychotic drug, which include typical drug like uh, haloperidol, chlorpromazine, thioridazine, or atypical like risperidone, amisulpiride, or zotipine. Antidepressant, which include tricyclic antidepressant, either amitriptyline or a clomiphene or serotonin receptor inhibitor like sertraline, fluoxetine, or MAO inhibitor, which includes several drugs like praline, pregaline, other antipsychotic drugs like buciprone, alprazolam, prokinetic like metoclopramide, domperidone, antihypertensive drug like alpha methyl dopa, Respirin, verapamil, opiates like morphine, H2 antagonists, which include cimetidine and ranitidine, other drugs which includes fenfluramine. So there are this huge number. There is very large list of the drugs which causes hyperprolactinemia. So before we are labeling that the patient is having a pathological cause of hyperprolactinemia, all other causes, whether it is a physiological or whether it is a drug induced, should be excluded. Mechanism of hyperprolactinemia in different clinical setting. Primary hypothyroidism and adrenal insufficiency usually causes increase in the TRH level, which causes increase in level of the prolactin. Certain medication which affects the dopamine, like neurogenic or chest wall stimulation or breastfeeding, they act via dopamine to causes negative effect on the prolactin secretion. Pregnancy and polycystic ovary disease, because of there is hormonal change and increased level of the estrogen, which causes increased level of the prolactin. Similarly, certain chronic kidney disease, there is decreased clearance of the prolactin. There are various pathological conditions like prolactinoma and other cellular mass. Pathophysiology is increased secretion of prolactin from this cellular mass. Or there are rare causes of the idiopathic hyperprolactinemia when none of the cause can be identified. Coming to the hyperprolactinemia and infertility, hypersecretion of the prolactin leads to the infertility and the gonadal dysfunction by interrupting the secretion of gonadotropin releasing hormone and inhibiting the release of the LHH and FSH and impairing the gonadal steroidogenesis. Prolactin inhibits the estrogen synthesis in the ovary also. In 20% of the secondary amenorrhea, hyperprolactinemia prevents the ovulation by impairing the normal follicular development. Coming to the hyperprolactinemia induced hypogonadism, increased serum prolactin level results in a decrease kispeptin expression, that is a KIS1 neuron in both hypothalamic and antroventral periventricular nuclei, mediated by the prolactin receptor, which is expressed in both the population of the KIS1 neuron. So suppression of the kispeptin in turn reduces the release of the gonadotropin release hormone and results in loss of the ovarian gonadotropin releasing hormone surge. This leads to the reduced pituitary gonadotropin secretion, that is the LH and FSH, and there is loss of the ovarian stimulation, which usually occurs under the stimulation of the pituitary gonadotropin, and thereby results in the hypogonadism, infertility, and amenorrhea. Prolactin may also have a direct effect on the gonadotropin releasing hormone neuron or the pituitary gonadotrop or other gonadotropin releasing hormone efferent neuron. Now coming to the prolactin levels, normal prolactin level in men is less than 20 microgram per liter. Non-pregnant women, it is usually less than 25 microgram per liter. Pregnant women, usually the level is elevated, which we have already discussed. It is a physiological cause of elevation of the prolactin level, and it is in the range of 80 to 400 microgram per liter. Underlying condition of the prolactin level are either which causes elevation of the prolactin or prolactinoma. In prolactinoma, the levels are usually more than 150 microgram per liter, maybe 4 to 5 times higher than the normal value. In the macroprolactinemia, the levels are significantly elevated. Macroprolactinoma is defined as a tumor size more than 10 millimeter. So this case, the overall prolactin level is more than 250 microgram per liter. In some cases, it may be more than 1000 microgram per liter. Psychoactive drugs, estrogen, and functional idiopathic or macroadenoma values are between normal and 100 microgram per liters. So level sometimes helps to differentiate the cause of the hyperprolactinemia. Coming to the signs and symptoms of the hyperprolactinemia, in females, it may cause secondary amenorrhea, it may cause oligoamenorrhea, it may leads to the anovulatory infertility, it may cause galactorrhea, or it may leads to the hypogonadotropic hypogonadism. It may causes amenorrheic women with estrogen deficiency and aggravate the osteoporosis. Macroadenoma is associated with the visual symptoms and headache. In male, it may lead to the hypogonadism, it may cause decreased libido, erectile dysfunction, infertility, gynecomastia, galactorrhea, macroadenoma associated with the visual symptoms and headache. So visual symptoms and headache may occur in both the male and female when there is presence of macroadenoma. So if the male patient comes to you with erectile dysfunction and infertility with gynecomastia, you should evaluate this patient for macroadenoma also or other causes of hyperprolactinemia. Now coming to the clinical presentation of hypoprolactinemia in the premenopausal women, if the prolactin level is between 31 and 50 microgram per liter, there is a short luteal phase, there is a decreased libido, there is a decrease in there is a infertility, there is increased chances of uh, weight gain, there is a chances of osteopenia because the estrogen and progesterone. Usually, estrogen is essential for the bone health, and because of the hyperprolactinemia, the estrogen secretion may get decreased because of the decreased level of GnRH and overall decrease in the pituitary gonadotropin level. So ultimately, the bone health may be impaired. There is a degree of bone loss may be occur in these patients. In patient, those who are having a very high level of the prolactin, there is increased possibility of galactorrhea also. In male population, hyperprolactinemia presents with the decreased libido, impotency, decreased sperm production, infertility, gynecomastia, and rarely galactorrhea. Galactorrhea is very rare in the male population. When galactorrhea is present, the prolactin level may be very high. Impotency is unresponsive to testosterone treatment, and it has been associated with a decreased muscle mass, and body hair and osteoporosis. Now coming to the prolactinoma. The most common pituitary cause of the hyperprolactinemia is the prolactinoma, which accounts for 25 to 30% of the overall functioning pituitary tumors. Prolactinoma are classified by their size. We have previously discussed macroprolactinoma, that is a more than 10 millimeter or more than 1 centimeter. Microprolactinoma is usually less than 10 millimeter in size, that is less than 1 centimeter in size. Prolactinoma presents are commonly in females, and microadenoma are more common in the premenopausal women, and macroadenoma are more common in men and the postmenopausal women. Based on 2017 WHO classification of pituitary adenoma, morphological variants of lectotroph adenoma are sparsely granulated, or they may be densely granulated, and the acidophilic stem cell adenoma, which also express the growth hormone. Diagnosis and investigation of the hyperprolactinemia. Based on the clinical evaluation and biochemical testing and MRI imaging, these are the modality on which we can diagnose that the patient is having a prolactinoma, and cause of prolactinoma can be identified. So in history, we should take the proper history of the drug intake. We should able to take the good history of menstrual cycle, whether the patient is having oligomenorrhea or amenorrhea. Galactorrhea history should be taken. Physical examination include the visual field defect should be done in a patient if we are suspecting for the pituitary macroadenoma, because the peripheral visual field may be get affected. Breast discharge should be examined. Laboratory investigation include pregnancy test should be ruled out because it is one of the physiological cause of the hyperprolactinemia. Thyroid function test, because we have already seen that hypothyroidism is one of the important cause of the hyperprolactinemia. So hypothyroidism should be ruled out. Other condition includes the laboratory investigation, which includes the pregnancy test, which includes the serum creatinine and anterior pituitary function assay should be done. MRI of pituitary should be done, which to rule out the pituitary tumor. The reported reference range for total prolactin on Abbott assay is 2.7 to 19.7 microgram per, let's say, per liter for male and 3 to 26 microgram per liter for the female. Coming to the macroprolactin level, macroprolactin causes macroprolactin is also one of the important cause of the hyperprolactinemia. Though there is actual cause is decrease in the prolactin clearance. The macroprolactin is a native prolactin that has been bound with the immunoglobulin, and it is usually having a high molecular mass, which is 150 to 170 kilodalton in size, compared to 22 kilodalton of the monomeric prolactin. Macroprolactin is a non-bioactive prolactin and isoform. Macroprolactin is a non-bioactive prolactin isoform, usually composed of prolactin monomer and IgG molecule having a prolonged clearance rate similar to that of the immunoglobulin. So this isoform is clinically non-reactive, but it interferes with the immunological assay used for the detection of the prolactin. So macroprolactin is usually less bioactive as compared to the monomeric prolactin, but when we done the bioassay, there is increased level of the prolactin has been found. Hook effect in hyperprolactinemia. Hook effect occurs when very high serum prolactin level, usually more than 500 microgram per liter, are present. It causes saturation of the capture and the signal antibody used in the immunoradiometric or chemiluminescent assay, preventing the binding of two sides in a sandwich assay. So it may show the result of an apparent prolactin concentration that is only modestly elevated, suggesting that macroadenoma is clinically non-functioning. The artifact can be avoided by repeating the assay with a serial dilution. So this effect can be avoided by using the serial dilution of the serum. To establish the diagnosis of hyperprolactinemia, single measurement of serum prolactin, the level above the upper limit of normal range, usually confirms the diagnosis. In patients with asymptomatic hyperprolactinemia, assess for the macroprolactin level. When there is discrepancy between the very large pituitary tumor and mildly elevated prolactin level, serial dilution of serum sample to be assessed for elimination of artifact that may occur sometime with the immunoradiometric assay, leading to falsely low prolactin level, which we have seen with the hook effect. So hook effect can be avoided with the serial dilution of the serum level. Coming to the management of hyperprolactinemia, so evaluation of hyperprolactinemia requires detailed history, symptoms of high prolactin level, symptoms of potential causes of medication, potential causes and the medication history. If hyperprolactinemia is present, whether the patient is having a persistent hyperprolactinemia or whether the patient is also having the symptoms of mass effect of the pituitary tumor, and assess for the macroprolactin level also, depending on the prolactin assay. So check for the TSH level, check for the serum creatinine, check for the liver function test, because we have already seen some of the patient of cirrhosis is also having elevated level of the prolactin because it is get degraded in the liver and kidney. If the other causes of the hyperprolactinemia like drug or renal impairment or hypothyroidism is ruled out, then we should go for the pituitary MRI. If pituitary MRI suggests the presence of the tumor, it may be either a pituitary microadenoma or macroadenoma, or it may be because of the other cellular masses or other causes. If cellular masses causes compression of the stalk, it also causes elevation of the prolactin level. Idiopathic hyperprolactinemia is usually occur when all the causes of the elevated prolactin has been ruled out. Coming to the management of the hyperprolactinemia. So objective of the treatment of hyperprolactinemia is restoration and maintenance of the normal gonadal function, restoration of the normal fertility, prevention of the osteoporosis. This is the one of the important factors for the treatment of the hyperprolactinemia. If pituitary tumor is present, then definitely correction of visual function and neurological abnormality is also one of the important perspective of management. Reduction of removal of the tumor mass may be required if the patient is having a macroadenoma. Prevention of the normal pituitary function is also important in patients of those who are having a macroadenoma. They may affect the other pituitary hormone secretion, and prevention and progression of the pituitary and hypothalamic disease should also be taken care of. Most of the prolactinoma are managed with the medical therapy, and only rarely surgery or radiotherapy is reserved for the refractory cases. So coming to the medical treatment, dopamine agonist is one of the important therapeutic agent which has been used to treat the hyperprolactinemia, which include cabergoline. It can be administered once or twice a week, usually available in dose of 0.25 milligram twice a week, or it can be increased to 0.5 milligram once a week. Bromocriptine administered twice a day, which is given in the range of 1.25 to 2.5 milligram orally at bedtime, usually with the dinner. Maximum dose is 15 milligram per day. So coming to the dopamine agonist, the important fact is that cabergoline is the first drug of choice because of its efficacy and fewer side effects. Cabergoline is preferred to the other dopamine agonists due to the higher efficacy in normalizing the prolactin level in the tumor shrinkage. Bromocriptine is preferred during the pregnancy because of the more favorable data than cabergoline. Cabergoline has a greater affinity and selective for the pituitary dopamine 2 receptor and longer duration of action, and it is indicated in case of the bromocriptine resistance or in case of the bromocriptine intolerance. Coming to the indication of surgery in the prolactinoma, usually the transsphenoidal surgery is preferred and the surgical option is required. Tumor size increase despite of optimal medical therapy, that is the indication of surgery. If patient is having a pituitary apoplexy or the oral treatment intolerance is there, or if the patient is having a macroadenoma which is refractory to treatment with the dopamine agonist, or microadenoma refractory to treatment with the dopamine agonist in women who wants to conceive, optic chiasm compression, cystic prolactinoma, CSF fluid fistula, or macroadenoma in a psychiatric patient in whom dopamine agonist is contraindicated. So these are the indication of surgery. Coming to indication of radiotherapy in prolactinoma, radiotherapy is rarely needed in the management of the prolactinoma. In patients with big tumor who are not candidate for surgery and who do not respond to the dopamine agonist or cannot be treated with them in patients with aggressive prolactinoma or carcinoma. Radiation primarily used to prevent the regrowth of residual tumor in patients with a very large macroadenoma after the transsphenoidal development. After 1 month of therapy, the patient should be evaluated for the side effect and serum prolactin should be measured. If the serum prolactin is normal and there is no side effects, we can be continued with the oral therapy. If the serum prolactin has not decreased to the normal but no side effect, the dose should be increased gradually to as much as 1.5 milligram of the cabergoline or 2 to 3 times per week, or 5 milligram of bromocriptine 2 times per day. If the prolactin has been normal for 2 or more years and there is no edema seen on the MRI, discontinuation of drug is considered. Coming to the hyperprolactinemia in pregnancy. Hormonal changes in pregnancy. During pregnancy, the estrogen level increases and there is a concomitant hypertrophy and hyperplasia of the lactotrough. The maternal increase in the prolactin level also occurs soon after the implantation and concomitant with the increase in circulating estrogen level and may reach up to the 200 nanogram per ml during the third trimester. The rise is directly related to the increased circulating level of the estrogen. Coming to the hormonal changes in the pregnancy, here we can see that the estrogen level gradually increases during the pregnancy, and with this estrogen level, here we can see that there is increased level of the prolactin level also. And at the end of the pregnancy, that is during the childbirth, there is significant increase in the prolactin level, which causes secretion of the breast milk. And after weaning, there is gradual decrease in the level of the prolactin. So despite of elevated prolactin level during the pregnancy, lactation does not occur because estrogen inhibits the action of the prolactin on the breast, most likely blocking the prolactin interaction with its receptor. A day or two following the delivery of the placenta, estrogen and prolactin level declines rapidly and lactation is initiated. Prolactin level reach basal level in long-lactating women, usually in 2 to 3 weeks. Although basal level of the circulating prolactin declines in the non-pregnant range approximately 6 months after the participation in lactating women, following each act of the suckling, prolactin levels increase markedly and stimulate the milk production for the next feeding. Coming to the management of hyperprolactinemia in pregnancy, there is no evidence of increased teratogenicity associated with the bromocriptine or cabergoline used during the pregnancy. Similarly, there is no evidence that increased risk of abortion or multiple pregnancy with the dopamine agonist use. If the tumor size before the pregnancy is less than 10 millimeter, dopamine agonist therapy is stopped during the pregnancy because the risk of tumor expansion is low. If the tumor size before pregnancy is less than 10 millimeter before pregnancy, more than 10 millimeter before pregnancy, bromocriptine use is advised during the pregnancy to avoid the significant tumor expansion. All patients should be evaluated every 2 months during the pregnancy. Formal visual field testing is indicated in the patient with the symptoms or history of the macroadenoma. If visual field defects develop despite of dopamine agonist treatment, early delivery or pituitary surgery should be considered. Women with prolactinoma should discontinue dopamine agonist therapy as soon as the pregnancy is recognized, and except for selected patients who have invasive macroadenoma or adenoma which causes optic chiasm compression. Serum prolactin measurement should not be performed during the surgery unless there is a clinical evidence of tumor growth such as visual field impairment. Routine use of pituitary MRI during pregnancy is not recommended in patients with macroadenoma or intracellular macroadenoma. Pregnant women with prolactinoma with experience severe headache or visual field changes should have a formal visual field assessment followed by MRI without contrast. Bromocriptine therapy in patients who experience symptomatic growth of a prolactinoma during pregnancy. Effect of cabergoline on pregnancy and embryo-fetal development. It is a retrospective of 103 pregnancy and a review of literature has been done. Observation, retrospective, and multicenter study of 103 pregnancy in 19 women with hyperprolactinemia. Serum prolactin at baseline were between 30 to 1921 nanogram per ml. These patients, the duration of therapy before pregnancy range from 1 to 120 months and fetal exposure range from 3 to 25 weeks. 96.9% of the patients received cabergoline during the first trimester of pregnancy. No significant complication during the pregnancy was found. Similarly, the no significant higher frequency complication was found in pregnancy or offspring exposed to cabergoline in the normal population. Coming to the cabergoline, cabergoline absorption and disposition is not affected by the food. Rapidly absorbed from the GIT with the peak level between 0.5 to 4 hours and 41 to 42% bound to the plasma protein. Elimination half-life is about 63 to 68 hours in a healthy volunteer and 79 to 115 hours in hyperprolactinemic patient. 10 days after administration, about 18 to 72% of the dose is recovered from the urine and feces respectively. Unchanged drugs in urine is accounted for 2 to 3% of the dose. On the basis of elimination half-life, steady state concentration should be achieved after 4 weeks. Cabergoline is a dopamine ergoline derivative with a potent, long-lasting prolactin lowering effect by direct stimulation of D2 receptor on the pituitary leptotope. Cabergoline has a higher dose. Cabergoline at higher dose has a central dopaminergic action. Cabergoline single oral administration of 0.25 to 1.5 milligram produces significant decrease in serum prolactin level. Up to 7 to 28 days in hyperprolactinemic patient, cabergoline has a prompt effect within 3 hours and it persists up to 7 to 28 hours in hyperprolactinemic patient and 14 to 21 days in puerperal women. Cabergoline has very selective action with no effect on the basal secretion of other pituitary hormone or cortisol. Therapeutic indication for hyperprolactinemia, inhibition of lactation and suppression of lactation. So doses of cabergoline can also be used for other purpose rather than hyperprolactinemia alone. That is the inhibition of lactation or suppression of lactation. So inhibition of suppression or suppression of lactation, the dose should be limited for a short duration. So treatment of hyperprolactinemia disorder, the recommended initial dose of cabergoline is 0.5 milligram per week given once or twice per week. The doses should be given on once or twice per week depending on the level of the prolactin. The weekly dose should be increased gradually by adding 0.5 milligram per week at the monthly interval level until the optimal therapeutic response is achieved. The maximum dose should not exceed the 3 milligram per day. Dose of cabergoline is up to 4.5 milligram per week has been used in hyperprolactinemic patient. Now, clinical evidence. Cabergoline in the treatment of hyperprolactinemia, a study of 455 patients, retrospective study of 455 patients, 102 males and 353 women with pathological hyperprolactinemia. Cabergoline normalizes the prolactin level in patients with bromocriptine resistance or intolerance. A comparison of cabergoline and bromocriptine in the treatment of the hyperprolactinemia, randomized multicenter 24-week duration with 459 women 16 to 45 years with hyperprolactinemia was treated with the cabergoline. And this study demonstrated that there is a stable non-prolactinemia was achieved in 186 out of 223 women treated with cabergoline, 83%, and 138 of 236 women treated with the bromocriptine. So cabergoline is more effective and better tolerated as compared to the bromocriptine in women with hyperprolactinemia. Treatment with hyperprolactinemia, systemic review and meta-analysis, 8 randomized study which include 178 non-randomized study over 3,000 patients were analyzed. Compared to no treatment, dopamine agonists significantly reduced the prolactin level and persistent hyperprolactinemia. Cabergoline was the most effective than bromocriptine in reducing the persistent hyperprolactinemia, amenorrhea, and oligomenorrhea and galactorrhea. The treatment with hyperprolactinemia, systemic review and meta-analysis has been suggested that percentage of patients who are having adverse effect with the bromocriptine. Cabergoline has a better patient tolerability as compared to the bromocriptine. Here we can see that with the cabergoline, nausea, vomiting, hypotension and headache, all such side effects are significantly less. So, effectiveness of cabergoline in prevention of ovarian hyperstimulation syndrome has also been demonstrated in those patients who are having, who are undergoing for ovarian hyperstimulation patient. So, to summarize, hyperprolactinemia is a symptoms of the reproductive dysfunction, galactorrhea, and it mostly affect the women's. Diagnosis can be confirmed by the single serum measurement of the prolactin level. Majority of the patients with hyperprolactinemia can be successfully treated with the dopamine agonist. Cabergoline has a first-line drug of choice in the patient of hyperprolactinemia, and it causes significant restoration of the gonadal function and marked reduction of the tumor size also. Thank you.